I would also point out that, with many people that do have mood disorders, a lot of times it's just, we really look at it as the brains are unhealthy in some ways. It's not always psychological stress. They have injury to their brain or they have inflammation in the brain. They have various risk factors that are causing early neurodegeneration or activating their immune system. And then they get this vicious cycle of the psychoneuroimmune effect. And now you have a person who is, stuck in a web and they're having a hard time getting out of it.
Welcome to the Mind Health 360 show. I'm Kirkland Newman, and if you, your loved ones, or clients suffer from mental health issues such as depression, anxiety, insomnia, poor memory, poor attention, mood swings, exhaustion, etc., I interview the leading integrative mental health practitioners from around the world to help you understand the root causes of these symptoms, many of which may surprise you and suggest solutions to help you heal. If you like this interview, please do subscribe and forward to others who might find it helpful. If you want further information, please go to www.mindhealth360.com or find us on social media. Dr. Datis Kharrazian, welcome to the Mind Health 360 show. I am so thrilled to have you here. I have been a big fan of yours since forever, since your first book, Why Do I Still Have Thyroid Symptoms, came out, which I read cover to cover and completely defiled with all my notes, but it's absolutely brilliant. And your next book, Why Isn't My Brain Working, is an absolute Bible, and I can't recommend it highly enough to everybody who has a brain, which is all of us. Just to talk a little bit about you, you have a very long bio, which I will put fully in the show notes, but just as a sort of summary, Dr. Datis Kharrazian is a Harvard Medical School trained and award-winning clinical research scientist, academic professor, and world-renowned functional medicine healthcare provider. He develops evidence-based models to treat autoimmune, neurological, and unidentified chronic diseases with non-pharmaceutical applications. His clinical models of evidence-based medicine are used by several academic institutions, thousands of healthcare providers throughout the world. Dr. Kharrazian is an associate clinical professor at Loma Linda University School of Medicine. He's also a fellow of the American College of Nutrition, a diplomate of the Board of Nutrition Specialists, a member of the American Society for Nutrition, a member of the American Association of Immunologists, and a fellow of the Royal Society of Medicine here in the UK, which is where I'm based. As a medical educator, you've developed many postgraduate courses in blood chemistry analysis, hormone and endocrine management, complex immunology testing, gastrointestinal management, and various topics in functional medicine. And due to the growing demand from healthcare professionals to learn your clinical models to manage chronic diseases directly from you, you've developed the Kharrazian Institute, and your courses at this institute are attended by a worldwide audience of more than 3,000 physicians and healthcare providers. Both your books, which I just mentioned, Why Do I Still Have Thyroid Symptoms When My Lab Tests Are Normal, which completely changed the paradigm of how thyroid disorders are managed, and your next best-selling book, Why Isn't My Brain Working, have been incredibly well-reviewed, exhaustively referenced, and have really changed a lot in sort of the world of functional medicine, functional neurology, and a functional medicine approach to brain disorders. So we owe you a huge debt of gratitude for your work, and we're incredibly grateful.
Thank you so much.
We'll dive right in and say, what is functional neurology? Because a lot of our audience may not know.
Yeah, so functional neurology is really defined as a model where you're trying to evaluate function and not disease. So, for example, if a person has some degree of balance issues and instability, that's an aspect of function. That can lead to significant health problems and falls, but it's not necessarily full-blown disease of, let's say, area of the brain called the cerebellum. Or if someone has cognitive decline in the early stages, they may not have Alzheimer's or dementia. So we really want to look at the early stages. The best way to think of it is like the gray areas before someone develops black and white neurological disease. And then the goal of intervention is to improve function. And when we say function, we mean like, how do we improve neuroplasticity, how neurons connect together? How do we slow down neurodegeneration? How do we optimize pathways integrating with each other? And those are usually done through diet, nutrition, lifestyle strategies. So it's a way to identify brain disorders early and then to look at interventions to improve brain function.
And it's fascinating because, one of the statistics that sort of comes out in your books is that, neurological disease can really start 15 to 20 years before the symptoms actually manifest. So say Parkinson's, before you get tremors, you can get gastrointestinal symptoms, up to 20 years before you actually develop symptoms, obvious symptoms of the disease. And you also mentioned that in MRI scans, until, for instance, in the case of multiple sclerosis, until 70% of the myelin is destroyed, you can't actually see it on a normal MRI scan. Say only 40% is destroyed, you still can't see it. And yet, once 40% of your myelin is destroyed, you would want to know about it, because there's a lot that can be done to prevent the loss of, the increasing neurodegeneration. And so I think it's really crucial that we manage to adopt this approach, which is a functional approach, because otherwise we're wasting huge amounts of time in mainstream medicine, waiting around for, as you say, the black and white sort of telltale signs. So it's incredibly important. My next question is about psychoneuroimmunology, which is a sort of fascination of mine, which is essentially how the immune system and the nervous system and our psychology interact. So, Mind Health 360, I'm very interested in depression, anxiety, mental health issues. But I'm also very interested, because of my recent experience with mold toxicity, in neurodegenerative issues and things like, muscle fasciculations, tremors, dizziness, sort of more neurological loss of cognition, memory, concentration, etc. And there's this fantastically exciting field of psychoneuroimmunology, which I know that you're an expert at, which is still somewhat controversial in mainstream circles. But I'd love to hear your take on it and sort of, what is it and how is it developing?
Yeah, it's a big field. I don't think it's very controversial in the world of neuroscientists and neuroresearchers. It may be controversial with an average care or healthcare provider that really doesn't know what they're doing as relation to that field. And the typical, self-defense of someone who doesn't know that science will just, it's not real. But there's scientific journals dedicated to that field. There's institutions at every major university focused on psychoneuroimmunology. It's not really, I don't think it's very controversial. But I think in the field, what researchers are showing, as far as the application to depression and other related mood disorders and neurodegenerative diseases, where there's a big gap with a conventional healthcare provider and what the research is showing. But for the most part, what we know is with psychoneuroimmunology that there's a dramatic impact of brain function on the immune system. And when we talk about the immune system, we mean the immune system in the brain, which are these glial cells, and also systemic immunology. And then we know there's an area of the brain that's involved with processing emotions, the limbic system, and this limbic system activation can cause immune responses throughout the body. And, when you look at the indicator that all research studies are judged against, whether it's valid or not, is a placebo effect. And so you have to do every study against a placebo effect. The placebo effect is a psychoneuroimmune response. It's a person thinking that they're going to take something and have some benefits. That's a psychoneuroimmune response. So the entire world of research is based on this phenomenon they know to be very, very real. And if they don't account for it in a study design, then the study is not really valid, or it's a very poorly done study. So our thoughts, emotions, the frequency of firing, the activation of our brain can really have a direct impact on our immune system. There's then various concepts in that field, like neurogenic inflammation, where severe amounts of psychological stress can activate different inflammatory mediators throughout the body. So when you're under a lot of physiological stress, you can have things like substance P and different neuropeptides release in your peripheral nerves, and now you have inflammation throughout your body. You can have your gut be inflamed. You can have, let's say, irritable bowel syndrome, and you have some inflammation in your gut, but that mixed with psychological stress really activates and flares that up. Lots of research has been done on that specific field. So it's basically this concept of the brain, triggering the immune response in both positive and negative ways too. I would also point out that, with many people that do have mood disorders, a lot of times it's just we really look at it as the brains are unhealthy in some ways. It's not always psychological stress. They have injury to their brain, or they have inflammation in the brain. They have various risk factors that are causing early neurodegeneration or activating their immune system. And then they get this vicious cycle of the psychoneuroimmune effect. And now you have a person who is, stuck in a web, and they're having a hard time getting out of it.
Yeah, it's really interesting because, I work with a lot of sort of trauma practitioners as well, who are really into the sort of more emotional, psychological aspects. And I'm fascinated by the biochemistry. And it's always sort of what comes first. Is it the adverse childhood experiences that lead to chronic stress that then have this sort of neurodegenerative footprint on the brain? Or is it that, you're predisposed to a sort of sensitive brain and inflammation genetically and in terms of your lifestyle that then makes you more sensitive to psychological and physiological stressors, sort of chicken and egg thing?
Yeah, for sure. And they're both involved, but at some point people do get a vicious cycle.
Yeah.
And then, but they don't treat both sides. That's where they can't get out of it.
That's exactly right. And that's why I call my website Mind Health 360, because I think you have to treat all the sides in order to get well. I mean, that's the key thing. And I'm fascinated by inflammation, particularly because more and more we're discovering that both neurodegenerative issues, mental health symptoms are a result of sort of inflammation, which is chronic, essentially. And can you sort of explain the mechanism? Like, how could you explain that depression, anxiety, insomnia, but also dementia, Parkinson's, even autism, ADHD, OCD, all these sort of brain phenomena are linked back to inflammation? What is the mechanism? Is there one common denominator, or does it vary according to each pathology?
There's a bit of both. So ultimately, when you look at the brain, there's really two types of cells. There's neurons, and then there's these cells called neuroglia. And neurons, we're all familiar with. They have neurotransmitters. They cause electrical impulse. There's a neuron. There's pathways. There's different regions of the brain. The other cell in the brain are these neuroglial cells. And there's different types of neuroglial cells, but for the most part, these neuroglial cells are the immune system of the brain. And actually, if you weigh the mass of the brain, 2/3 of the mass of the brain are these glial cells. There's actually more glial cells than neurons in the brain. And so there's more immune cells in the brain than there are actually these neurons, which we think is all brain. And these glial cells, they used to think were just there to attach neurons together. They called them glia because of glue cells. And then there's been an explosion of research that has shown, wow, these are profound cells, and they have impacts on everything from the efficiency of neuron transmitting to get rid of debris and so forth. But the main one we want to focus on when we're talking about pathophysiology of different diseases is these microglial cells. And these microglial cells are these cells that basically get rid of debris in the brain. So just from normal function, cells start to lose their function, and they start to degenerate, and these glial cells get in there and just eat them up. So then we have healthy synapse pathways between one neuron to another. And these glial cells also, if there's lots of branches in certain pathways of a neuron, they'll get rid of the branches that are inefficient to make sure brain work better. So these glial cells have these really important functions of optimizing our neuron connections and pruning the pathways that are not efficient, and also getting rid of any debris, so we have these clear pathways. But they can get into a heightened state of activity, which causes brain inflammation and neuroinflammation. And the common feature of autism and the common feature of modern day understandings of depression and the understandings of neurodegenerative diseases is these glial cells are in an inflammatory state, and they're in a constant inflammatory state. So then these microglial cells, they have the potential to express in what's called an M1 pathway, which is pro-inflammatory, or an M2 pathway, which is anti-inflammatory and protective. So they can help growth factors to help neurons branch. They can also help modulate the synaptic cleft area where neurotransmitters are. So they have all these diverse functions. But one of the features of, for example, autism is these glial cells are primed. And priming is something that happens also with brain injury. And the injury could be traumatic, or it could be chemical. It can even be emotional. And these glial cells, what they do is they actually have these like legs that move around, so they get rid of debris. They lose their legs, they become an amboid structure, and then like no legs, and they're called primed glial cells. These primed glial cells, once they become primed, they stay primed. It's like a hard-boiled egg. You can't go back the other way. And once these glial cells get primed, they're in a constant state of M1 inflammation. And they're just causing constant inflammation in the brain. And when they do that, they lose their M2 activity, which is like protective, and they lose their efficiency of like modulating neurotransmitter cleaning and synaptic cleft, and they're just causing inflammation and just they're basically chewing up everything around the area. And then they're also activating other glial cells to do that. And this is one of the mechanisms of why when people get a brain injury, they have symptoms years and years later, because one group of cells get injured, the glial cells prime, and then over the next few years, they spread like a forest fire. Now the entire brain's inflamed. Then 5 to 10 years later, they start to have severe symptoms, even though after the initial injury, it wasn't that obvious. So these glial cells churn into this primed state, which is permanent, and they start churning on these other cells. Now, once these glial cells are primed, it takes very, very little inflammation to activate them. So for example, let's just say someone has a reaction to milk protein, and they drink a little bit of milk, and let's say for a person that doesn't have severe inflammation of these primed glial cells and they react to milk, they may get a little bit bloated, they may get a little inflamed, but it's not even that big of a deal. They don't really notice it too much. But for someone who's got primed glial activity in the brain, they may get exposed to milk proteins, all of a sudden have severe activation of these glial cells. These inflammatory mediators we have in our body, like in our gut and our tissues, they cross the blood-brain barrier and they turn on these glial cells. And then once these glial cells get activated, they just create severe inflammation. And when they create inflammation, neurons get destroyed. And also inflammation disrupts normal neurotransmitter signaling activity. So then the brain slows down, it can't do its functions, and then you have a whole host of different symptoms. Now, it's important to understand from a clinical point of view is that where these glial cells are primed is going to be specific to the symptoms. So I'll give you an example. Let's say someone has this injury where they fall back and hit the back of their head. And the back of the head, there's the area of the brain called the cerebellum. And that's an area of the brain that calibrates your vestibular input so you have balance and you don't fall and you have stability. Someone who has those cells primed, they get exposed to the trigger, let's say we're saying sensitivity to milk or something, they will have like dizziness and instability. And someone else could have primed glial cells in their frontal lobe, and then they get that activated, maybe because their frontal lobe is injured, and they'll have focus, attention, concentration issues. And someone else has glial cell activity, these, let's say, frontal striatal projections, which is the area that dampens your limbic system from getting to an anxiety state. And all of a sudden, dairy proteins, they get this exaggerated response. So one of the clinical indications that someone has these primed glial cells is an unproportional response from inflammation that affects their brain. And then based on where their injuries are, and where these glial cells are primed, we can get a clue what's happening. Someone has got a parietal lobe injury on their right, then we'll see like numbness and tingling on their right side. So they have these weird symptoms, and they tell people, and they go, "Hey, you're crazy. These things don't make sense," but they're actually primed glial cells. Now, when you look at, for example, children with autism, when they do they've had incidents where they can do postmortem studies with children who have died right after birth. Their brains show their glial cells are completely activated. That during their development, they had these primed glial cells develop. It's one of the key features of autism pathophysiology. So they're born with these primed glial cells. So during fetal development, there was an inflammatory process that took place that then turned these glial cells on. And studies have shown things like when a mother has an infection during their pregnancy, the risk of autism skyrockets. If a person that's pregnant is like close to a freeway, a major highway, their risk for autism goes up. So you add some of these risk factors together, and then that may create a plate where these glial cells get turned on during pregnancy. And that's for example, the mechanism of pathways, one of the main mechanisms of autism. And then when you look at all neurodegenerative diseases, frontal temporal dementia, Alzheimer's, Lewy body dementia, it doesn't matter which one it is, one of the key features, these glial cells are activated and primed. Now you take a real life scenario where someone has had maybe played sports, maybe had a little bump in their head and nothing significant, they have a little bit of brain injury, but nothing to notice anything. But it's, let's say, to area of the frontal lobe. At the same time, they're starting to develop neurodegeneration. They're getting older. It happens to all of us to some degree, right? So maybe they're pre-diabetic and those little insulin surges and fatigue after meals are starting to cause inflammation in their brain. And now maybe they're in a area where they live that's high degrees of air pollution, and they're breaking all this air that's been shown to activate these glial cells. And these things start to add up, and now all of a sudden they have severe focus, attention, concentration issues, and maybe depression. So, in the frontal lobe, especially the dorsolateral frontal cortex, is not firing well, and it could be happening from inflammation. You get depression. So those are what we see. So that's the summary of, like, I guess, to answer your question about inflammation, what's the same between different diseases? How are they different?
Well, I mean, that's amazing. I mean, for my first question is, why does this happen? Like, why is, once these glial cells are primed, why do they stay primed? Why is there no off switch? My second question is, why does it then lead to this rampant inflammation? Because it sounds sort of counterintuitive, and from an evolutionary perspective that would happen. It sounds like, it's sort of something that shouldn't happen. And then the other question is, once they start to destroy the neurons around them, we know that neurons, once they're gone, right? So you can improve plasticity by improving connection between the neurons, but you can't bring neurons back. This is pretty scary stuff, because, once they're primed, they'll continue, and it's like a forest fire. And then once they start to kill off neurons, then those don't come back. So why does this happen? It doesn't seem like it should. Yeah.
It's like, it's the same thing as, why do we have systemic inflammation? Because we have way too many triggers and enough anti-inflammatory defenses to protect us from it. So it's the same with the brain. Like, the brain gets depleted of antioxidants, and then the brain gets depleted of nutrients and essential fatty acids and the things it needs to function and stay healthy, and it has a load that's greater that's causing inflammation. You just get this disproportional response. So I mean, ultimately they're there to help clean debris in the brain, which is important, except they just shouldn't be totally wired to that level. Yeah. And maybe after some, acute injury, it's more important to get rid of the debris so neurons can connect again than it is to have some subtle inflammation. So, those are maybe some of the variables there. Or we sure, everything works perfectly, but we have this completely disproportional reactions our body is not adapted for, right?
For the environment that we're in. And I think that takes me to my next question, which is, so what are the factors? And you mentioned a few of them that really trigger this inflammation, this inflammatory response. You mentioned sort of traumatic brain injury. You mentioned toxicants, but if you can, food intolerances, but if you can take us through a list of the sort of, these things that we're bombarded with that trigger inflammation and trigger this immune activation, that would be helpful.
Sure. So there's a couple things to point out. One is, not all glial cells get primed, right? So let's just talk about non-priming first, because the same list applies to primed glial cells. But anything that's inflammatory, well primed, will activate these glial cells. So our brain is extremely vulnerable to inflammation, oxidative stress, free radicals. It just doesn't have a good antioxidant defense system. It really just doesn't. Certain tissues in the body just don't. The brain has a lot of resiliency. You can lose neurons, and the neurons can branch around them, and you have some neuroplasticity that can develop there. You can get neurons to have more mitochondria and become more efficient and do all these things. So there's a lot of resiliency to get an injury and then to recover by design, but it doesn't have a really good antioxidant, anti-inflammatory system. These glial cells have some, but the loads that sometimes people are getting are just exceed it. So anything environmental that increases free radical load, oxidative stress, like secondhand smoke, cigarette smoke, air pollution, they've all been shown in the peer-reviewed scientific literature to activate these glial cells. And there's direct relationships in many publications now where they show the air quality of where people live has a direct link to mood disorders, to neurodegenerative diseases. So like if you live in a really, polluted city, you're going to have an increased inflammatory load unrelated to anything you're in control of. It's just breathing the air out there. And then obviously some people have inflammatory conditions. Some people develop rheumatoid arthritis. Some people develop inflammatory bowel disease or Crohn's or ulcerative colitis or celiac disease, or, and then certain people start to, as they get older, they lose their immune tolerance. They start to develop food sensitivities and start to react to foods. And then all these things start to add up to the load of their inflammation. So then there's a load of inflammation, and if there's greater inflammation in the brain than neuroplasticity, connectivity, then the brain starts to degenerate. And over time, we all will have some degeneration of our brain. It's just we're hoping that it's not enough to cause loss of function, right? So over time, our immune system loses its efficiency, loses resiliency. We can't modulate inflammation as well, so we tend to start to have ability to counteract it impacted more, some much faster than other people. So that's like just general information. So, when you look at risk factors for neurodegenerative diseases, things like diabetes, things like inflammatory conditions in general, like underlying autoimmune disease or inflammatory bowel disease, these things all increase risk for neurodegenerative diseases. Then you have prime glial cells. So prime glial cells is a different story. Prime glial cells takes actual insult or injury to the brain to become primed. So the best example of that is trauma. Someone just hits their head. Okay. Chemical insults can absolutely cause injury to the brain. Things like carbon monoxide poisoning. If someone actually has a severe toxic load that can cross the blood-brain barrier, destroy the blood barrier, that can prime glial cells. And infections.
Yeah.
And, one of the studies we published in Frontiers Immunology right when the pandemic happened is we looked at 84 different tissue proteins, and we want to see what is the spike protein. There's different proteins of the SARS-CoV-2 virus, nuclear protein, envelope protein, spike proteins. So we checked all the different proteins to different autoimmune target sites, and we found, the neurons have cross-reactivity. So antibodies made against this virus can also bind to brain and cause reactions and cause inflammation in the brain. And some people had those reactions. Now, it doesn't mean it happens to everyone, because there's all these different variables with how the immune system responds to antibody response where those things happen. But I'm sure people that have long COVID that got the viral infection, the brain has never been the same.
And there's, I've seen studies, for instance, with Alzheimer's, that herpes 1 and 2 have been very linked to Alzheimer's. I think 98% of autopsies have signs of herpes 1 and 2 and Epstein-Barr and all these chronic viral conditions, and whether it's, Lyme disease, a bacterial infection, or, these all have these inflammatory effects on the brain. And
by the way, to add to that, we published a study in Journal of Alzheimer's Disease, where we showed that antibodies to many of these pathogens have molecular mimicry with beta amyloid, which is the marker for developing Alzheimer's disease. So we show there's an immune cross-reactive molecular mimicry mechanism of how these antibodies bind to these proteins and then promote more inflammation. So pathogens, for sure.
And I'm really interested in this sort of molecular mimicry, because one of the things I'm that you talk a lot about is autoimmunity, obviously. And so the link between inflammation and autoimmunity is quite interesting, because, say you get a biotoxin, whether it's a Lyme or mold, and that causes sort of chronic inflammatory response syndrome, for instance. Now, how do you know at what point this inflammation becomes an autoimmune condition? And, are there different symptoms? Or, you mentioned that there is some research coming out that Parkinson's and Alzheimer's and certainly autism have autoimmune components. But where do you draw the line, and how do you tell if it's just a sort of straight inflammatory response, like a chronic inflammation, versus an autoimmune condition?
Yeah. So autoimmunity, for those that may not be familiar with the term, it's just when the immune system starts to attack your own body. Autoimmune, right? So it's automatically just impacting your own tissue. It doesn't distinguish your tissue being different than a pathogen or a foreign invader. And then you get autoimmunity to specific proteins in the body. So many people have autoimmunity, and they may not have autoimmune disease, but I can help clarify that. But autoimmunity occurs when the immune system starts to make antibodies, and the immune system makes antibodies to target tissues for for immune cells like T cells and cytotoxic T cells, natural killer cells, the soldiers of the immune system to destroy. So once something foreign comes in, B cells of the immune system make antibodies. These antibodies then attach to the tissue. It just makes it easier for these immune cells to find them and makes it more efficient for them to kill them when these antibody proteins are attached to them. So anytime someone has antibodies to their own tissue, that's technically autoimmunity. And there are many, many people that have neurological autoimmunity. If you just take blood samples of a random population, you'll see sometimes 5%, 15% of the sample population has autoimmunity, meaning antibodies to these neurological proteins, but they may not have MS yet, and they may not have Alzheimer's yet, but there's this exaggerated inflammatory response. So, and it's standard testing. It's like myelin basic protein, myelin oligodendrocyte protein, neurofilament antibodies, alpha beta tubulin antibodies. Like any conventional lab anywhere in the world that has a medical lab will have these antibodies. They're not like esoteric. And these antibodies exist with many, many people, and many people don't know they have it. So that's another reason why people have significant brain symptoms and brain inflammation or mood disorders, because they actually have neurological autoimmunity. And if they did a blood test and checked for some of these antibodies, they may be able to find them. Like, for example, celiac disease has high amounts of neurological autoantibodies as a disease. And many inflammatory bowel autoimmune diseases have high degrees of neurological autoantibodies as well. So when someone develops antibodies, there is this intense immune response against that tissue because the immune system is attacking the brain as if it was a pathogen, especially when it gets aggravated. And anything that triggers an autoimmune response could be psychological stress, it could be lack of sleep, it could be catching the common cold, it could be food proteins that your immune system is really reactive against, it could be a combination of those things creating the perfect storm to trigger an autoimmune flare-up. Then a person could get neurological symptoms. And depending on where these antibodies are located, so for example, some people just have autoimmunity to GAD65. GAD65 is called glutamic acid carboxylase 65. That's the enzyme that makes GABA, which calms the brain down. Some people have GAD65 antibodies and they get severe anxiety when their autoimmune disease flares up because they don't have the inhibiting pathways of the brain. Some people have antibodies specific just to cerebellum proteins, and they get severe vertigo and nauseousness and anxiety from that when that gets activated. So people have myelin basic protein, so their entire brain gets inflamed because all their myelin sheaths get inflamed when their autoimmune response takes place. And this is found, for example, in bipolar disorders. Bipolar disorder, people have high amounts of neurological autoantibodies. They're fighting autoantibodies in Alzheimer's disease as a part of the mechanism. We've published some of that. I published some papers on Parkinson's disease and alpha-synucleinopathies having linked to autoimmune disease, and so have many other researchers. So we're seeing that some of this plays a role into the whole inflammatory cascade, but it's not the feature of all Parkinson's disease, not the feature of all Alzheimer's disease. The key feature is inflammation in the brain, and then these different proteins are involved for various variables that then cause different disease expressions. But autoimmunity is very real, and it's really ignored by the healthcare system. So, the first stage of autoimmunity is you just make antibodies, and that's known in the immunology literature as autoimmune reactivity. It's not a disease yet. And as the condition progresses, then they can have enough destruction of their tissue where now it'll show up like an MRI, like the example you brought earlier, where, myelin destruction less than 70% is not going to really show a signal. So they could have 30% destruction of their myelin, have blood measurements of elevated myelin antibodies, but not have any MRI changes where someone will be diagnosable having a brain autoimmune disease. And then they have this mysterious, weird mood disorder or cognitive issues and inflammatory issues. So there's like a disconnect of where researchers are focused in and what clinicians are really doing. There's like that gray area, which is always the case when people have conditions that seem weird and no one can figure them out.
Absolutely. But I guess my real question is, at what point, and you may not know, but at what point can you intervene and reverse it? Because we know that autoimmunity is not reversible once it becomes a disease. But presumably when it's just at the state of sort of antibodies, it can be highly reversible. And
yeah, so this is where like terminology and language can get confusing for people, and even for healthcare providers talking to each other and so forth, right? So, first of all, the good news is with any kind of injury to the brain and even glial priming, you can promote things like autophagy to get rid of glial cells, and you can promote neuroconnectivity. It's not all gloom and bad and hope. And even with autoimmunity, which technically is uncurable, what's realistic is to put people in remission where it seems like it's just not expressing itself. So there are, it's not all bad. I mean, there's things that are positive that can be happen. Technically, there is no cure for autoimmunity. They're just like in the world of immunology research and scientists. And if anyone ever discovers the cure for autoimmunity, they will absolutely win the Nobel Prize in medicine. It would be no doubt, it would be the biggest explosion of immunology findings ever. And this is why it's like so disturbing when you see people say, "Oh yeah, I cure autoimmunity all the time." You're like, well, go get your Nobel Prize in medicine, because that would be amazing. Why don't you actually show it? And what they're really doing is they're confusing a person getting in remission and not having as many symptoms as being a cure. So, for example, some people have autoimmunity and they find out, hey, I can't eat gluten and I have to be off this food and I have to really do these lifestyle factors and really get sleep. And I really have to support my gut health to maintain not having any symptoms. And then their neurological symptoms may go away. Maybe their brain fog, their mood issues, brain fatigue, all those things could dramatically change. And some practitioners that know what they're doing may say, "Oh, that was a cure." It's not a cure. It's just remission, right? And even their antibody levels can go down to zero or like not identifiable. Doesn't mean they're cured. It just means they're in remission. But they could have like a severe life stress, and maybe they have someone in their family pass away, or they get in a car accident that injures their body significantly, and everything can go right back up. So that's the key thing. So remission is very clinically realistic. It may be misinterpreted as potentially a cure. And again, it just depends on the terminology people are using. So that's, I think, where it gets frustrating.
Yeah, and it's important because obviously, you think, okay, if you discover these neuronal antibodies or even normal sort of other antibodies like ANA or so you say you can actually get them back to zero, but you still have in the background that pattern where if you are going to have a major stress or a major exposure to whatever triggered you in the first place, you'll go right back there because that's your pattern. Is that how you sort of react genetically? That's your go-to reaction? And is that presumably completely individual, that when faced with some massive stress or physiological stressor such as a mold or a gluten, you will then develop those antibodies because that's your sort of go-to response?
Yes. I mean, I'll try to answer it the best way I can. Okay. So for example, mold is a great example. Mold mycotoxins with the right perfect storm can turn on autoimmune disease in some people and then not in others. You could have a couple living in a house that has toxic mold everywhere, and one person is like, "I don't know what you're complaining about. It's great to me." Another person just can't function in there, right? So there's this individual uniqueness of how the immune system orchestrates the response to it, and lots of variables there. Some we understand, many we don't. Okay, but that's clinically real. And then for some of them, for maybe one person, they develop antibodies to the brain. Maybe they get myelin basic protein, which is the most common, one of the common ones. So they may then start to develop not only mold sense like mycotoxin exposure, but their immune system then develops allergy to mold. They actually have on blood measurements IgE mold species. Like if you check their IgE, there's different mold spores, it's positive. So now they have this B cell memory of these mold species, and they will have it for the rest of their life. Right? That's the concept of memory B cells. And now they go into a damp building, get exposed to some spores, and then boom, their autoimmunity flares up. And since their antibodies are against their brain, they'll have neurological symptoms. But also, maybe they have antibodies against their joint. Maybe they have cartilage antibodies, and joint peptide antibodies. And they get severe arthritis and joint pain. Or someone else also has antibodies to the brain. Maybe they have it to the skeletal muscle. And now they have deep muscle aches and pains. So, and most people that have autoimmune reactions have it in multiple tissues. So it's not just one. So it's they used to think it was like organ, like specific to one, but once autoimmunity develops, what happens is what's called loss of immune tolerance, and then different antibodies show up in different tissues, and people usually have more than one. And that's a difficulty too. Like in a clinical scenario, we'll see a patient that has weird, diverse symptoms, and they're all over the place, and they have many, many different chief complaints. And then when you really look them up, you go, oh, you have 5 different tissue antibodies, and your symptoms could be explained by all these 5 antibodies. And ultimately, you only have one real condition. Your real condition is autoimmunity. So how do we change the expression of your autoimmunity? And that's how it kind of works.
And once you're sensitized, you're sensitized. I mean, that's, yeah.
I don't know. I mean, there's people that, there's some people that do low dose antigen therapy that can sometimes treat allergy. That's been effective in actual research publications that are very critical of all types of therapies. So some people do respond to low dose antigen therapy for mold that develop it. Some people never respond to that therapy. There's people try esoteric things, people try homeopathy. I mean, you got to try everything when you're in it and you have all this time and you're suffering. So, why not?
Yeah.
And various people respond to various things. And, it's not the same treatment for everyone. And that's, the difficulty with these multivariable diseases,
Absolutely. And one of the things also you mentioned when you talk about chemical sensitivity is this sort of tolerance, the tilt factor, and the fact that you basically become, it's not really the chemical that you're reacting to anymore. It's the immune system's reaction to the chemical that causes the symptoms. Can you explain that a little bit, the tilt factor?
Yeah, of course. So, when we look at chemicals, for example, the traditional model is to look at something called chemical load. Like you have a certain amount of chemical, it's safe, you're not dead, oh, you're dead, that's too much, and then you stay below that, right? So like safe levels of lead, there is no safe level. Like safe levels of mercury, we allow this amount of mercury. And now there's the debate in the US of how much lead is allowed in baby food. The answer should be none. But they're trying to go, well, this amount's okay. They're like, no, it's not. But anyways, that's based on a certain load, and over time you can get your load and then get sick. There's an entirely different model of a chemical mechanism how it makes you sick, and this is where the immune system loses tolerance. So you get exposed to a chemical, but instead of having just load and these free radicals destroying your cells, the immune system starts to react against those chemicals. And part of the process is chemicals bind to proteins. Proteins change their structure. When the proteins change their structure, when they're bound to a chemical, they become a new protein. And the immune system looks at that as a new protein and starts to create inflammatory responses against it. And in those cases, the total load doesn't matter. You get a trace amount of exposure and be really, really sick. You could have someone who just gets a little bit of exposure to gasoline fumes, petrol fumes, and then boom, they're sick, they're flared up, and that's loss of chemical tolerance. Now, people, when they develop autoimmunity, they lose immune tolerance, which is their self. That's why they have autoimmunity. They make antibodies against themselves. They also lose some degree of chemical tolerance. They start to react to chemicals more, and they also lose some degree of what's called oral tolerance, or also known as dietary protein tolerance, where they develop food sensitivities. So they get in this vicious cycle. They're not reacting to chemicals, they're reacting to foods. Their inflammatory responses are unproportional, and when they get their immune system triggered, wherever they have their antibodies at, maybe it's brain, maybe it's pancreas, maybe it's skeletal muscle, maybe it's their thyroid, those things all of a sudden get attacked because those antibodies are attaching to those tissues. And once the immune system revs up, those T cells are going to first go to whichever has antibodies attached to it and start to destroy those.
What about the programs that are designed to actually reduce your response? So I don't know, I'm sure you've heard of sort of Annie Hopper's DNRS, Ashok Gupta's limbic system retraining program, which is all about retraining the limbic system so that it doesn't have this disproportionate response to chemicals or to, your symptoms. So it doesn't create this sort of cascade. It's sort of a desensitizing program. Do you know about what's your view? Do you think those can be effective?
Yes, I think they can be effective, but for the right patient population.
Yeah,
that's the problem. It's like when we make generalizability to all patients. This is the same mistake that happens in conventional medicine. Conventional medicine is designed for what's called generalizability. You do a clinical trial. Your design of a clinical trial for a drug is that the more people that are candidates, the better. And then you have one, like a clinical trial has like an endpoint, change in blood pressure, change in depressive score, major depressive score, something like that. And then they usually have a lot of people in there, like thousands. And that's not to make the study better. That's just because the clinical effect size is going to be so small. When you have a large group, you get a statistically significant outcome. Yeah. It's actually much more significant when you have a very small population and they have a statistically significant change with any kind of treatment, because that means that the effect of that treatment was very powerful. Yeah. And there's like some studies published in the Journal of Medicine where their sample size of the study was 4 and they had huge statistically significant outcome. They're like, wow, that's an amazing mechanism, but it's generalizable to the whole population. So what happens is, like, that concept doesn't work, because when people have an autoimmune disease or have an inflammatory condition in their brain or have multi mechanisms impacting their mood or neurological symptoms or disorders, it's not one generalizable thing. It's not like you need to take St. John's wort to get rid of your depression. Like that. No, it's not that simple. Of course, it can have some impact, some degree with some people, but it's not that like you have a deficiency or some simple thing like that. So when it comes to these techniques where they retrain the brain or promote neuroplasticity, different types of feedback, however they do it, of course, anytime you engage the brain, touch someone, have someone do any kind of stimuli, you're changing brain, right? And for sure, there's strategies with those therapies that impact people, get their heart rate under control, their stress under control, the autonomics under control. For some of those people, that could have a huge impact on their outcomes. But to say it's going to work for everyone is where the problem comes in. So I would say if you're suffering from a condition, you may want to consider it. But the problem is when it just becomes generalizable to everyone that has this and everyone's going to respond to it. No, not everyone's going to respond to it. And first of all, for example, if you're doing limbic retraining, what if the lesion's not in the limbic system?
True. Yeah.
And what if they don't have neuroplasticity potentials? What if the neurons can't connect? What if they can't make mitochondria? Then like no stimulus is going to work. As a matter of fact, you can make the person much worse because you're putting stimuli into a brain that doesn't have metabolic capacity to respond to it. So I think you could figure those things out if you knew how to do a really thorough neurological exam and you knew what the patient's fatigability levels were, and then you were able to like really understand what your intervention is doing to the brain. The problem is that's hard. Yeah. And it's not easy to do even with a top level clinician. Like there's too many variables for us to understand.
Understood. And in terms of, coming to the sort of what we can do about all this, because I mean, obviously it can be a little overwhelming.
Yes.
I think, what I'm hearing from you is you really do need to take this 360-degree approach where you look at everything. You look at your blood sugar balance, you look at your stress levels, your, food sensitivities, etc. I mean, and I know that you do a lot of sort of root cause. So you try to diagnose exactly, what is going on here? Is it a blood sugar issue? Is it an oxygenation issue? Is it that, a metabolic issue? Is it, a TBI, leaky gut, but we know it's all connected. As a clinician, how do you approach this sort of overwhelming soup of, it could be an infection, it could be poor diet, it could be a food intolerance. There are all these things that play into triggering this inflammatory response. How do you piece together this puzzle to look at the whole picture essentially and get people sustainably well?
Okay. So first of all, there's a lot of things that can be done. Okay, so second,
not all doom and gloom.
It's not all doom and gloom, but it's not like everyone needs to take this magic supplement or do this magic therapy. Everyone's unique, and without question, when it comes to brain and complex chronic disorders, there's definitely trial and error. Like you'll have to try something and see if it worked or didn't work. There's no way around that. It's not like you just go see someone and do all these tests and go, got it. So just to give you like some perspective of the my bias in the world I'm in. So I'll see a person come in as a patient and we'll do countless laboratories. We'll screen the gut, we'll screen the immune system, we'll do really thorough diagnostic testing, this neurological exam, and there's no shortage of information. We have all this information, okay? And doesn't necessarily mean that helps us get anywhere. It just helps us like have understanding the big picture. At the end of the day, you still have to trial and error. The most valuable clinical tool to let you know what direction to go in the history, the medical history. So, and this is what blows away, I think, some people when they come in and they do a thorough workup. And like a simple question I always ask in my forums, new patient forums, like, tell me everything that's helped you and tell me everything that's made you worse. It's like, okay, so why are you not doing everything that's helped you? Why are you not avoiding this made you worse? Like, you've already done trial and error. You already know. And then they're like, oh, wow, I do notice when I don't sleep, it has a huge impact on me. I'm like, okay, check. Let's put that in the treatment protocol. We got to optimize your sleep. I notice when I do take green tea, it makes a big difference for me. Okay, how much do you take? I do, well, I don't take it anymore. Why? I don't know. Okay, let's put some on. Do you figure out what dose you need, at high level, what level you need? No. Okay, well, let's figure that out. So like a lot of times then some things are obvious. Like, hey, do you know when your blood sugar levels drop, your anxiety gets worse? Yeah, maybe. Okay, well, let's stabilize your blood sugar levels. So it's almost like they already know. Like if they really think about it, they already know. And this is important because it's like, well, it's a 360 approach. You got to do everything. And then it's like, oh, I can't do everything. I don't even know what am I going to do? Like if everything's related, then like, well, I can't have wine. I can't eat any foods. I can't have any stress. I can't, and it's like, this is pointless. Like, it doesn't mean anything. So I think a really critical thing to ask yourself, which is clinically important as clinicians do a workup, what are the things that really help you? What are the things that don't? And sometimes it's a really unhealthy relationship that's a factor. The things that have the far-reaching effects that impact the web of the neuroendocrine immune system more than anything else is sleep, exercise, and another major one that gets overlooked is just blood sugar stability. Like those are main ones.
Yeah, and I mean, and food obviously as well. So whatever what you eat, carbohydrates,
sure.
which are very refined
and then foods you can break down to how does it cause your blood sugar stability, and then how does it cause inflammation and other factors as well, right? But it's kind of like when someone has, let's say you do a complete workup and there's like everything's off, right? Like you do a nutrition evaluation, the nutritional status is off. You do check their gut, their microbiome is off. They have pathogens, their immune system is inflamed. They have pesticides that are outside the lab range, toxic chemicals. They have whatever, whatever you want to add to that. Abnormal adrenal cortisol rhythms, abnormal melatonin rhythms, hormone imbalance. Okay. The biggest clinical mistake is to try to treat everything at once. Like that always fails. It always fails. So then you go, how do I get rid of some of the smoke screen? Like, so I mean, the simple one is like, can they sleep? Are they getting good quality sleep? Are they getting any kind of movement? Right? Because, for example, sleep is going to dampen glial activation. It's going to promote autophagy. It's going to promote clearance of even some of these prime glial cells. It's going to help with neurochemical activity. It's going to provide fuel. It's the only time in your brain where you're actually starting to have mitochondrial biogenesis and neuroplasticity connectivity develop. So if you're not getting sleep, you're taking 100 supplements and being on all these different hormones, it's going to have very little effect. So it's almost like sometimes the battle clinically is how do we get someone to sleep better? And that might take months to figure out like what to do with that. And then exercise is one of the few things that really raises brain-derived neurotropic factor off the charts and impacts all neurochemicals and actually turns on the messages for neuroplasticity and neuron connectivity and mitochondrial biogenesis, like all the things you have to have healthy recovery. So like a minute someone doesn't sleep well and they don't move, I can tell you clinically, you're not going to go anywhere. And like this search for the perfect treatment option, like here's the thing, let's say someone goes to limbic reconditioning training. If their brain isn't able to sleep, and let's say the therapy doesn't impact their efficiency to sleep, because maybe for example it does, and they're not able to move and have movement throughout the day, they're not going to respond to therapy. Even like when we do brain rehabilitation, when someone has a specific brain injury, we got to rebuild their frontal lobe and we have to get connectivity there. If they don't have the metabolic physiology to have the ability to respond to a stimuli efficiently, then they won't respond.
Yeah, no, so that makes sense. That makes total sense. And one of the things you really say, which really stuck with me from your book, is, the brain really needs three things. It needs oxygen, it needs glucose, and it needs stimulation. And, otherwise the brain won't be able to absorb any nutrients if it's not getting the right oxygen and the right circulation. And you make another point, which is if you have cold hands and feet, you're likely to have a cold brain, in the sense that, your circulation in your brain is probably not optimal if your circulation in your extremities is not optimal. I thought that was fascinating. And so I guess exercise would boost that. You also talk about a lot of sort of plant compounds that can boost circulation to the brain, which you take sort of quite regularly. Do you want to just tell us a little bit about, the circulatory compounds that improve circulation to the brain, and also compounds that dampen inflammation? Because you mentioned a couple that that are very, very effective in dampening inflammation, because obviously, one of the key takeaways is regulate your blood sugar so that you get regular sort of glucose into your brain cells, and, get regular oxygen and dampen inflammation. Like, what are the sort of specifics that people can do for those crucial sort of things for the brain?
Oh, sure. Okay, so let's start with oxygen first. Okay, like your brain has to have oxygen, and that means oxygen delivery. So if someone has poor circulation, then they're not getting blood flow to the brain. And blood is carrying hormones and neurotransmitters and neuropeptides and growth factors for the brain to recover. So if someone's, for example, taking a handful of nutraceutical support the brain, but their blood flow and circulation is terrible, they're just never going to get that blood, saturation of those nutrients to their tissues. And in addition, so we want to have ideal circulation. So when people have really, really poor circulation, the biggest thing is their hands and feet are really cold. They have like white nail beds instead of pink nail beds, and if they do a capillary refill time, it's just white and it's never pink in returns. And so you can like kind of check yourself and just see how cold your limbs are. Like you have to wear socks all the time, and your hands are always freezing. That means you have poor circulation. And one of the most common causes of poor circulation, people, just their blood pressure is too low.
Their blood pressure is too low.
Okay. Yeah. So usually we look at blood pressure, 120 over 80 is normal. And if you're systolic, your first number is like below 110, or your diastolic is below 70, let's say you're 100 over 60, like you don't have perfusion. You can't push blood into your tissues. So low blood pressure is great for reducing your risk for a stroke because you don't have that pressure against your arteries, but it's terrible for ideal physiology, ideal function. So low blood pressure is a big issue. So sometimes we'll things like salting foods and licorice, and also high intense exercise can improve blood pressure physiology and dynamics. And then some people just have poor circulation. It's not necessarily related to blood pressure, but it could be high blood pressure, high or low blood pressure. There's some nutraceuticals that have been shown to help with circulation. What they do is they activate what's called vascular endothelial nitric oxide synthase. And the most common one, easiest to find, is ginkgo biloba. Ginkgo biloba, like it's easy, it's cheap, everyone has it. It's not hard to find. And if you just start taking ginkgo biloba, you would have this change in your systemic circulation, also blood flow to the brain. And people always ask, like, what's the dosage? Listen, with the brain, we don't know. And for each individual person, so you just start whatever one you buy, start with one capsule, and then see how you feel. And if you don't feel an effect, take 2. And then if you don't feel effect, take 3. If you feel effect with 3, try 4. If 4 is no different than 3, stick with 3. And then how long does it last? It lasts 8 hours. Great. 8 hours later, take another dose. And this observant to what kind of change you're getting. So ginkgo biloba is the easiest one. So let's just stick with that one. There's a lot of variations on different things.
There are a lot in your book.
Exactly. People get frustrated. Yeah. But that's the easy one. So that's the key thing with like oxygen. Take things that improve oxygen to the brain. Take some ginkgo. Make sure your blood pressure's not low or even high. Ginkgo will help with both because it impacts the vascular modulation dynamics.
What and then let's say the hyperbaric oxygen chamber, which is all the rage. What's your feeling about that?
For sure, it's helpful, especially after an acute brain injury. Like an acute brain injury, it can be life-changing, especially in the first 6 months. The sooner you get in, the better. Long-term use, I think, has some benefits too. It's just how accessible is it? Is it expensive? If you have one, well, you should go in there if we can use it. It'd be great.
Cool.
But it won't be as profound if you have normal physiology and function. It's just when you're dysfunctional. And a lot of times people notice. They'll go in and just go, everything cleared up after my session. So you're like, I don't notice anything. So if everything clears up after your session, you need to keep going, because it's a sign that you need that oxygen push into your tissue. And then as far as inflammation goes, anything that's inflammatory is a problem. So food proteins that are inflammatory is a problem. And not get too exhausted down that list, but you got to reduce inflammation. If your body hurts, if you eat something, you get swelling, inflammation, it's something you have to avoid. Most common ones for the brain are going to be milk and wheat. Milk protein, wheat protein are so inflammatory, and they have direct cross-reactivity molecular memory mechanism with the brain. And it's the two most important things to reduce. And literally with children that have autism, we can't even get any chance to change until they go gluten dairy free and get that inflammation out of their brain with those specific two food proteins. And same with MS. MS patients clearly notice severe change in function only when they start to go completely gluten dairy free. So it's like these two proteins are so inflammatory, especially for the brain. So those are the most two common ones. And all it takes is adding a little bit of milk to your tea or coffee. All it takes is like a little bite of bread, or not checking a condiment or sauce that has gluten in there to not achieve an anti-inflammatory state, because those inflammatory responses can last for a period of time. And then, so you want to reduce triggers for the inflammatory part. And then, as far as nutraceuticals that dampen brain inflammation, the most published nutraceutical is curcumin, turmeric, but not like curry spice chicken. Like you have to have thousands of milligrams of curcuminoids. So 2,000 to 3,000 milligrams of active curcuminoids to really have an effect on the brain. The other highly published one is just fish oils. EPA, DHA have been shown to have significant anti-inflammatory effects, and they're easy to find everywhere. So you get some ginkgo, you get some fish oils, you get some active curcuminoids in a supplement form. So you have concentration there. Now you're getting some big change there. And then the other one is just blood sugar stability. So to get glucose to the brain efficiently. So if you get shaky, lightheaded, and irritable, and when you eat, you feel like you're normal and can think again, then your blood sugar is dropping. So you got to eat frequently enough to not let your blood sugar drop.
What's your view, though, in terms of blood sugar with ketogenic diets, which sort of use ketones as opposed to glucose for brain fuel?
So with people that are severely, some people have severe tendency to be hypoglycemic, let their blood sugar levels drop, which means physiologically, when their blood sugar gets low, they have inefficiency of having pancreatic release of glucagon and adrenal function of cortisol to get those levels back up. If someone has constantly missed meals their whole life and just hasn't eaten, or has like an apple for a meal or smoothie for a meal, these systems get depleted, they become inefficient. And then when they try to go into like ketosis, they may have a really hard time, and they may it may be very difficult. They can still do it. It may be harder. And especially if they try to do like time restricted feeding, they're gonna like go, I know it's good for me, but it's making me crazy. I've never been worse, So I would say ketosis is fantastic for reducing brain inflammation. Clearly, they show ketones aren't just fuel for the brain, but they dampen brain inflammation. And when people have severe brain injuries, severe brain inflammation, we clinically have to put them on a ketogenic diet in order for them to start to recover, because we got to get that inflammation out. So, and then when we get to like prime glial cells, inflammation, ketones have been shown to turn off the M1 signal of prime glial cells. And sometimes we'll have people, once they get into ketosis, actually take exogenous ketones as a supplement to further dampen their inflammation. And even for people that are hypoglycemic in between when their meals are crashing, have them take some ketones, and that'll help them with their energy crashes. Ideally, if you're looking at bigger pictures for brain function, time restricted feeding and also fasting can really help get rid of those unhealthy cells of the brain, those prime glial cells and injured neurons. They call it, as everyone knows, autophagy, turning on that autophagy signal. So did I answer your question?
Yeah, it totally does. And then, not to interrupt you, but is there not a sort of tension between the intermittent fasting, which enhances autophagy, which then gets rid of the prime glial cells, which is key, versus your blood sugar control, where you don't want to go too hypoglycemic, because then that's a problem for the brain? How do you manage that balance, and how do you know if you're doing it right?
Yeah. Well, let's just, before we go there, I just want to add one other thing. There are some people that are not hypoglycemic, but they're insulin resistant. So when they eat a meal, they just get tired and crash.
Yeah.
And then for them, they have to, like have more fiber in their diet, more protein, and just go off sugar and carbs, and to the point where they don't pass out after time they eat. So those are like the two main: low blood sugar and high blood sugar. Both of those will respond to a ketogenic diet. So with those that are hypoglycemic, they can easily go into a ketogenic diet but they have to eat healthy fats regularly. And, like you give a hypoglycemic ketogenic diet, the first thing they see is, oh, I can have berries. And all of a sudden they're eating like berries the whole time. They're like, no, you could only have like a few, and you have to measure your ketone levels. And why don't you just use some avocado and olive oil, or get a nice piece of salmon? And so healthy fats are good. And then the other problem we see with people, so ketogenic diet works great for both. And if they can get into ketosis, and actually it's really important to measure ketone levels to know you're actually in ketosis. Blood would be ideal. You can get these, blood draw tips. If not, you can use urine ketones, but you got to get into actual ketosis and know the diet that's getting you to ketosis. And once someone gets to ketosis, their body starts to use fat for fuel efficiently, and the mitochondria are more efficient for fuel. It's much easier for them to then do time restricted feeding. So if they, let's say, go on ketogenic diet for 6 weeks, and maybe they're just going to do it for a few weeks, just get some inflammation down, or maybe they have insulin resistance, they're just trying to lose some weight, or whatever the case may be. And also when they go to ketosis, people that have exhausted adrenal glands, their adrenal glands start to recover because they're not playing the blood sugar roller coaster, right? So it's a really good way for a few weeks, people that have low exhausted adrenal glands, like hypoglycemic, or people that are insulin resistant, to take the stress off their insulin receptors to just get into ketosis. And once they get into ketosis, they'll notice as your body becomes more efficient using fat for energy, and mitochondria uses ketones, they just won't be as hungry. So they'll wake up and they may like not feel hungry. So doing a 16-hour time restricted feeding or an 18-hour becomes much, much easier for them.
Yeah.
And that's one of the easy ways to transition. Now, if we translate some of the research from animal studies on fasting, which is where they're all done, when they look at postmortem, like cutting the brain up and see what's happening, and you really need 3 full days of fasting to really make big change in brain autophagy. Like just an 18-hour fast is not going to do it.
That's very interesting.
So when we work with patients that have severe brain injuries, and we're trying to get them to recover, many times we'll use ketosis, get them a ketogenic diet, and then they'll start doing time restricted feeding, and then we'll do like a round of, maybe start with 1 day fasting and then work their way to 3 days. Then once they're able to do a 3-day fast, while they're doing their fast, they're drinking water and electrolytes and salt and exogenous ketones whenever they're starting to get low. You just can't have any protein, just the ketones and water and salts and minerals. And then we'll do 1 round of 3-day fast. Then we'll do another round. Sometimes we'll have to do 20, 30 rounds of 3-day fast over the next year and a half to start to clear all those injured cells and prime glial cells out of the brain. So it's not as, so some people are like, well, I did the fasting, didn't work. You're like, yeah, I mean, you're not going to get all of it out in one go.
And presumably you have to do it with the practitioner, because it's very delicate in terms of measuring your blood levels, your blood sugar levels,
I think if you stay under 3 days, you should be okay on your own, and there's really no point to go past 3 days. I mean, the key thing is if you have blood pressure issues and you're going to pass out and you're hyperglycemic, it's always best to work with someone who can hold your hand through the process. But once you get past 3 days, you also start to lose protein. And that's a main issue. And then if you look at like the studies that are done on fasting, like growth hormone goes up 100% first day, second day 300%, next day over 1,000%. I mean, these BDNF levels, these opioid levels, these plasticity biomarkers, they completely change the messengers for mitochondrial biogenesis between like day 1 and day 3. And they're nowhere like what you're going to get with like an 18-hour fast, So we'll have some people that have like traumatic brain injury. We'll go through with them. They're like, nothing's helped me. And they feel like they can't do anything. And we'll start getting them into ketosis, giving some ketones. Some of their brain fog typically lifts, but they still have brain endurance issues, brain fatigue issues. And then we'll do then we get them to the point where they can do 1 round of 3-day fast. And they do it. How do you feel? Like, I feel the same. Okay. You got another one coming up. How do you feel? And then another one. And then they like get into like number 6. of 3 days. And then they're like, I think I might notice something. Great. But I'm not sure. Okay, keep going. I get to like session 10 of the 3 days. They're like, I really think it's making some degree of difference. I'm like, great. Just keep going until you can start clearing that out. And that's the process. And that's the thing with the brain. Like when people understand the mechanisms, how these things work, as a patient, they get frustrated because they're reading stuff online and trying to do these things, but these things take repeated activities. And then if they're a practitioner, they don't know that, and both the patient and practitioner are like, how do you feel? Did it work? It didn't.
Yeah.
You're so difficult. You're so weird. You know what I mean? And in reality, it's like, no, it's a process.
It's a process. And then, I mean, I have so many questions, and I'm very conscious that I've already taken a huge amount of your time. But I guess just to, there are a few other key salient points. One of them is the link between, we all think of neurotransmitters when we think of mental health. We think serotonin, dopamine, acetylcholine, and GABA, which are the four that you talk about in this book.
Yeah.
And one of the key things is to keep those, functioning and not too high, not too low, etc. What is the relationship between those and inflammation, and also between hormones and inflammation? Now, these are big questions, and I don't want you to have to go into the whole thing, but I know there's a huge relationship between hormones, neurotransmitters, and inflammation. And if you could just sort of touch on that, that would be interesting.
Okay. So it's of all the various mechanisms to impact the brain, going through the neurotransmitter directly is the least effective.
Okay.
And the most effective is sleep, glucose, oxygen, because they actually optimize neurotransmitter physiology and function, right? And there's definitely direct research that inflammation disrupts serotonin metabolism into an inflammatory pathway. So we know that's there. There isn't as clear of an indication to what it does to acetylcholine and its other mechanisms from an inflammatory point of view, but I'm sure it's just a matter of time. So there's those kind of relationships. And then the whole world has really looked at depression, mood disorders as being like a neurochemical imbalance. And that, I think, is mostly done because they started to promote antidepressants. And, when they really look at the large data of meta-analysis of these studies on neurotransmitter modulating drugs, they're very ineffective. And the entire field of medical research, the area of all researchers point out to where research was done wrong and corrupted, it's antidepressants. Like the entire medical literature field, like when they want to give bad examples, what not to do, it's the antidepressant research that's been done. Okay. So we know there's big problems there. And so I think it's like least efficient. I know, like, and even when you play with neurotransmitters in the clinical point of view, like, for example, let's say someone has a GABA deficiency or symptoms of GABA dysfunction, you use valerian root or passion flower or something, it has an effect on them. It never lasts. Like, it's not forever. Like, you
because
always
the root cause is not being treated.
It's just the body adapts. And so it doesn't, like, so they're using like valerian to fall asleep or CBD to fall asleep, and then doesn't work anymore. And then maybe they increase their dose and that works a little bit more, and then it just stops working. Like that always happens. So yeah, someone takes like 5-HTP or something, they have an effect for some time, and then because as you increase your load, receptors, your receptors for these neurotransmitters are constantly rebuilding and regenerating, and then your clearance and there's all these variables that kind of adapt to whatever you're doing, and the little boost you were getting from it doesn't have the same effect anymore, and then you're like, oh, I thought I was just serotonin deficient. I just needed 5-HTP forever. And it really doesn't work that way. So we kind of always look at those as how long is your honeymoon phase? Okay, you used it. How long is your honeymoon phase? And for some people that have like serious GABA issues, we'll say, okay, well, if valerian works for you, use it when you have to. Don't use it all the time. Because when you start using it all the time, it just doesn't work anymore. So we'll say, like, if you have a sleep crisis and just can't sleep, use it. If you use it daily and regularly, it just loses effectiveness over time. So that's one of the issues with it. And then when you look at the mechanisms of how all neurotransmitters are made, fundamentally, you need glucose and oxygen to drive these pathways. So it goes back to underlying hypoglycemia and inflammatory pathways and circulation pathways and things like that. And hormones, by the way, they just have all been shown to impact glial cells. They just dampen the glial cells and they help with neurogenesis. So They all seem to have an effect. Progesterone, DHEA, estrogen, they all seem to have this anti-inflammatory effect and neurotransmission effect. But when levels are low, like when levels are normal, you don't get more anti-inflammatory effects by taking excess hormones. You can create other risk factors.
That's really interesting. So basically, the hormones are very anti-inflammatory. We know that inflammation then, sort of imbalances neurotransmitters. So really, you need sort of optimal hormone balance to then dampen the microglial activation so that you then have normal neurotransmitter or optimal neurotransmitter function. And what you're saying is that, yeah, you can sort of dabble with giving people neurotransmitter supplements, or you can, or precursors. Yeah, but the main thing is sort of getting the nutrients to the brain, managing the blood sugar. And is there anything else? Like, what are the sort of root causes of, I mean, we've discussed them, but
of neurotransmitter?
Yeah, neurotransmitters, but also hormone balance. Like, if you go all the way back.
Right. Okay. So I'd also point out just really quickly, there's been an explosion of research in emergency medicine where they're finding when someone has a severe car accident, has brain injury, if they immediately give them some progesterone and DHEA, their survival rates dramatically change. And this is now a practice that's being done in many emergency rooms in the U.S. after brain injuries. Trauma centers are just putting them on hormones to help dampen that brain inflammation. So in unrelated deficiency in states of injury to the brain, they seem to be also very effective. Now, what causes hormone imbalances? Let's talk about males really quickly. The main cause of hormone imbalances in male is inflammation. And in male, like we talk about primary hypogonadism, where they're not making testosterone and the testosterone levels are low and their LH levels are high. The pituitary is trying to get it to work. These are failure of Leydig cells. Leydig cells are the cells in the testes that produce testosterone. And these cells are also very vulnerable to inflammation because they don't have any antioxidants to protect them. And these lytic cells regenerate every 6 to 10 weeks. They become new cells and then they die off but when there's a higher state of inflammation in their system, they don't regenerate. This is why we can take like someone who's 14, 15, 16, 18, 21 and see significantly low testosterone levels. So a lot of times when we just reduce their inflammatory load, we can see those levels come up. Okay. If they go on testosterone therapy and then they start throwing off their feedback loop and start suppressing their luteinizing hormone stimulation of testes and they start to get gonadal atrophy, like they're on it. Once a person starts testosterone replacement therapy, many of them it's forever. It's for life. So it's not like you want to jump into that. You want to try for this mechanism. The other main mechanism that happens in males that causes hormone imbalances is they start to convert their testosterone into estrogen. So they make testosterone, but their estrogen levels go up, and their testosterone may even be normal, but their estrogen levels are higher. So they lose their androgen dominance. And this primarily happens from insulin. So there's an enzyme called aromatase in body fat, and insulin activates it in men. And these testosterone levels convert to estrogen. And this is why some men take like androgel hormones and testosterone gels, and then they get their blood test back, and it looks like they've been taking a estrogen cream. To make sure that the pharmacist didn't give them the wrong prescription. So those are the two main ones. In females, I would tell you the number one cause in my practice that I've seen over the years is just a female that's been hypoglycemic and they just constantly let their blood sugar levels drop. That'll throw off their pituitary feedback loops. That'll throw off their FSH LH efficiency. That'll throw off their ovulation. And I can't tell you how many times we've seen females normal, like let's say menstruating female age group, normalize their cycles just from stabilizing their blood sugar. The second close to that is they just don't have enough healthy dietary fats. So you have to have essential fatty acids for hormone signaling pathways and especially for uterine feedback loops with the pituitary. Yeah, those are definitely prostaglandin dependent. So a lot of times we see someone who's got like these abnormal cycles and menstrual abnormalities or hormone deficiency patterns forever or infertility, and we just get them to not get shaky, lightheaded, and irritable by stabilizing their blood sugar levels and go, hey, you need to have some fats in your diet and have some olive oil and avocado oil and borage oil and black currant seed oil, flaxseed oil. Just mix these up throughout the day and just have different versions, different days, and that'll have a huge impact
and also cholesterol. You mentioned cholesterol being so important for hormones.
Yeah, and then I think with cholesterol, we see levels drop below the 150 range in the US marker range. When it gets really low, suppressed, we can see androgen imbalances for sure.
Got it.
Hormone imbalance.
One final question, because you've been so generous with your time, is sort of the gut. You talk a lot about the fact that you can often tell brain degeneration when you start to get gut symptoms, and you look at it sort of in that direction. So we know it's a bidirectional communication between the brain and the gut. But what's fascinating to me is that, I've always thought of it's the gut that determines what happens in the brain, whereas you really look at it the other way around, and you see the sort of brain degeneration, which then leads to gut symptoms more in that direction. So it leads to vagal inefficiency, which then leads to gut issues. And what interested me was, if you know, so the 80% of the nerve fibers that go from the vagus are afferent, meaning that they go from the gut to the brain. And only 20% are afferent, meaning that they go from the brain to the gut, apparently. And so I'm just curious about this, because when I read what you're saying, it seems that a lot of sort of gut issues start in the brain. Can you talk us through the link and what the mechanism is?
So for sure, there's a gut-brain axis, meaning different metabolites in the gut, different bacteria, different polysaccharides, different cytokines, different gut hormones, different gut peptides impact the brain directly by going up the vagus neurochemically, or by putting placed in circulation that crosses the blood-brain barrier. So there's no question there's a brain-gut axis. And then there's even the field of psychobiotics now in literature. Researchers are finding different bacterial species can cause things like anxiety and mood disorders and different types of changes. So it's an evolving field. So different bacteria, we look at bacteria, but bacteria also have what are called postbiotic end products. So bacteria produce postbiotic end products, different lipopolysaccharides, different types of sugars, and these different lipopolysaccharides directly impact brain and neurotransmission and function. So that's an evolving, very exciting field that's happening in the world of neuroscience. And there's, some really good research happening in that field. But there's also research, especially in the neurology world, we're looking at traumatic brain injury, how brain function impacts the gut. So ultimately, gut function, the brain fires into the brainstem. The brainstem has the vagus nerve, the vagus nuclei, and the vagus nuclei has a motor branch, which controls contractibility of the gut and closure of valves. When that's not working well, people get motility issues and get constipation. And when their valves don't close, bacteria from the large intestine goes into the small intestine, and they get things like small intestinal bacterial overgrowth and those things. But the vagus apparatus also has an autonomic division, which promotes blood flow to the gut. So if there's an ideal blood flow to the gut, you can't heal leaky gut, you develop leaky gut issues. And then all enzyme production, gallbladder release of bile, hydrochloric acid release by the stomach, pancreatic enzyme release, they're all done by vagus activity. So in animal studies where they injure the brain, unfortunately, and then they see the effects, they can see leaky gut within the first three hours, even sometimes in 2 hours. They just see their gut totally destroy. And then within 6 days, 7 days, they have like atrophy of their gut, and their gut is completely inflamed. And the blood-brain barrier opens up when after brain injury, their glial cells get primed. There's glial cells in the gut too. The gut has its own nervous system, the enteric nervous system. Those glial cells can get primed. They can have people have ongoing immediate motility issues when they get inflamed, because the glial cells stop neurotransmission. The inflammation slows down nerve conductance, so they can have all these types of symptoms. So you get a vicious cycle, sometimes of both. Like autism is a great example of that. You have abnormal neurodevelopment from day one of being born. These glial cells are primed at a heightened state. Their brains don't have full migration of neurons. They don't have proper neuron connectivity. And then their gut doesn't work. And now their gut has abnormal blood flow, abnormal autonomics. They get dysbiosis. They get severe inflammation. And then they eat foods that are inflammatory, that then fires their brain and causes brain inflammation. And then their brain circuits aren't functioning. They have gut issues, and they have this like gut dysfunction. This happens with people. Sometimes people that I'll see patients that have chronic gastrointestinal issues. No one's like, they tried everything. And then you look at their history and go, you were in a severe motor vehicle accident. You were unconscious in the hospital. Like, oh yeah, but you don't have any good issues then. You're like, right. this inflammatory cascade may show up 5 to 10 years later, that chronic traumatic encephalopathy model. So there's definitely those mechanisms. And sometimes people once one starts, they start to perpetuate each other.
It's a vicious circle. And I guess the question is, clinically, what do you treat first? And how do you, so you can do all these stool tests and say, okay, you've got gut dysbiosis, you have leaky gut, so we'll treat that. But if you're not treating the brain, then it's just going to continue. And so would you say you have to treat both simultaneously, or do you have to try to identify where the source is coming from and then treat that?
I think, well, first of all, I think clinically, you can't just, we have to for sure know that they have a vagal issue, because not everyone that has like injury or dysfunction in the brain or mood disorders or chemical imbalances is going to have vagal dysfunction. So the biggest clue, first of all, someone has vagal dysfunction is, number one, they have motility issues. They can't get their intestines to work. So they're like the ones that have to take magnesium to soften their stools every day to function, or they have to take some kind of motility stimulating, with a peppermint tea or whatever they have to take to have bowel movements. That's like your first clue. Okay, that vagal system is not interacting. Okay, now that could just be the gut itself. Different, like methane or hydrogen. These things have impacts on motility too from bacteria, but that would be a clue if they have motility issues. Another major clue is they can't swallow. Mm-hmm. So we'll hear from patients like, please, if you can give me a powder instead of a capsule for supplement, that'd be better, because I really have a hard time swallowing. The swallowing is all vagal. So if we see like vagal issues, and then sometimes they just, another big clue is that dry mouth, and they can't swallow well. And the biggest clue of that is they're still finishing their meal, and it's 30 minutes, 40 minutes, an hour later when everyone else is done. So when you see inefficiency producing saliva, they can't digest their food. What happens with vagal issues, just like the gut's not working. And then they don't even really know they have really a dry mouth. It's not that significant. And they also have to take really small, like to chew the food over and over again to even swallow. This is all done subconsciously. They don't know. So if someone has extended, eating time consistently with whoever they eat with, or just, they have chronic constipation issues, they're really swallowing. That's when we really start to suspect this descending vagal system is involved. Now, in a clinical exam, we can have them say, you see those punching bags in the back of the throat, they should move really quickly. And then if you do that 10 times in a row, they should always work. Sometimes when people have injury to that system, their endurance is an issue. So they can do the first one and say, and then like the punching bag, the palate moves up. But when they get to like 3 or 4, it just stops moving, because they don't have the mitochondrial capacity there. And a lot of times we can hear it. We can put a stethoscope in their abdomen, and when you listen to the abdomen, there's like gargling noises, and it has an intensity and a frequency. People that have vagal issues, like there is no intensity. You can barely hear it, and then there is no frequency, and then it'll be in different quadrants all throughout. So those would be our clues. And then in the brain book, I talk about like gargling to activate that system, because you can't do it with a supplement. You have to actually activate those neurons to move. So gargling is probably the easiest one, using a tongue blade in the back of the throat to just a gag reflex, singing loudly. Those are all ways to start activating those vagal pathways.
Yeah, and I mean, I'm going to let you go, because you've been amazing with your time and you've given us so much information, but there's so much information in this book in terms of, it's a brilliant book in terms of, each chapter is summarized. You have a ton of different suggestions on supplements to take and exercises and tests and, sort of compounds that are supportive. And so I have to say this book is really, it's a total Bible. And of course, the thyroid book is still wonderful as well. And so I highly, highly, highly recommend all those for further information. But Dr. Kharrazian, you've been amazing. And I have to say, I'm so grateful. And keep up the amazing work. And thank you for your time. And we'll put all the details of where people can find you and your biog and everything else in the show notes. But really grateful for your time. Keep up the great work. Thank you.
Thank you so much. You too. Thanks. Good job.
Thank you so much for listening to the Mind Health 360 show. I hope that we've helped you realize that mental health symptoms have root causes that can and need to be addressed in order to sustainably heal, and have given you some ideas about steps you, your loved ones, or clients may take to start their healing journey. Please share this interview with anyone you think may find it helpful, and don't forget to subscribe to keep up to date with our latest interviews on integrative mental health. If you want further information, please go to www.mindhealth360.com or find us on social media. This information is for educational purposes only and is not intended to diagnose or treat any disease or to replace medical advice. Please always consult your healthcare practitioner before discontinuing any medication or implementing any changes in your diet, lifestyle, or supplement program.